Good afternoon, and thank you so much for coming and for making the longest trek from one end to the other end. I'm Victor McConvey. I'm the current chair of the healthcare professional section, and this is my co-chair, Hanneke. We've also got our incoming Pan-American chair sort of sitting in the audience, which is Maria over there. So we also need to acknowledge that this meeting wouldn't actually be made possible today without the support of the Movement Disorder Society and also the exceptional administrative support we get from Sam Cirillo, who you would have met as we came in today. So we really extend our most significant thanks today. But right now we've actually got a range of really diverse speakers and it's really very multidisciplinary in nature and quite diverse range of topics. Really reflecting the way that we care for people living with Parkinson's and other movement disorders, in fact that it's very much a team approach.
I'd like to put to the podium John Dean, our next speaker. John Dean is a speech therapist and he works at the Davis Finney Foundation in Boulder. And we are happy that he is here to share with us his thoughts on user-centered approaches to designing technology for Parkinson's. And he told me this weekend that he loves to work with technology. So the floor is yours, John.
All right. Great. So as you mentioned, I'm a speech therapist by training, kind of a nerd by devotion, and I work for the Davis Finney Foundation and I make technologies for Parkinson's. And I'm going to talk a little bit about some of the learning that we experienced this year, some of the potential barriers, and maybe some tips when you're trying to develop a technology project. Very quickly, if you're not aware of our foundation, if you don't know the Davis Finney Foundation, our mission is to help people living with Parkinson's to live well today. It's very much focused on quality of life, and we have a number of projects and programs focused in that space. So I was brought on about a year ago to start a program called the Virtual Community Project, and it became a platform of technology, tools for living well. And the idea was we wanted to give the members of our community some data and other helpful information that they could use very quickly, that they could take action with, and that was a big focus of the project. And we're not looking for more data, we're looking for the right data. So potential barriers when you first start working with a development team is that they might not really be very sensitive to the needs of a person with Parkinson's, and they're not designed that way. So we obviously know that there are going to be fine motor issues, and there are going to be visual spatial challenges, and obviously cognitive changes, and especially if you're inundating them with too much information, or even their healthcare providers report that as well. If you give the healthcare providers more information than they need. I was at a session in New York and there was a doctor who says, I don't want more data, I want the right data, and then I want it at the right time, and I think that's a good way to look at it. However, I think a really under-recognized potential barrier is failing to bring the people with the Parkinson's in early at the outset and keeping them involved all the way through that, and that becomes part of the user-centered design that we're talking about a little bit. So the first thing we did was make a nice survey. So we take some more time to learn about our audience, and I definitely recommend that. You can get a lot of great information quickly, but as you'll find, a survey can be very binary. You know, it's a snapshot, and you're really getting this picture for just a moment, and it's difficult for them to give you additional information. Really, the most valuable part of this survey, as we put it out, was the final question. Would you like to have a conversation with us? And that's very important because those people do want to talk to us. We had hundreds of responses, way more than I could manage very efficiently. And so the first thing I did is I started separating these people into different cohorts. I started making basically an advanced data set based on some basic demographics. And some of it's pretty straightforward, you know, male or female, married or single, working or not, time since your diagnosis. But then we started looking at other interests. You know, I live in Boulder, Colorado. There's a high level of exercise in my part of the country. That's not universal, and it was good to get a way to break them down into cohorts based on those habits, or their technology interest, or other things that they're doing outside of Parkinson's and tech. So I would definitely recommend that if you can break it into these groups, it allows you for a very efficient way to have a better conversation. And so our next project was a sub-project where I started looking at wearables. If you look at some of the posters that are available out there in the session today, which is on technology, you'll see an awful lot of really great tools, but it can be difficult to get people to continue to use them over and over again. And we were looking at wearables as a possible way of improving compliance. And so a persona is really just a composite of a number of people. So we found a group of people within a certain cohort, and we talked to them. We interviewed each one of them, and we started asking them very open-ended questions. And we came up with, these are the 3 initial ones. There's actually another one on the way. But it became a great way to look at a project, at a wearable project. We were looking at one, and based on this top one, this low-effort Lewis, we might not be approaching that way. And it was a great way to shortcut some of the other ways to look at a project. And I definitely recommend doing something like that because ultimately we need to find ways to get meaningful insights, and we need to do it quickly. We're a nonprofit. We don't have tons of money to burn. And so we're using those personas, and we're keeping in mind the following questions. What are we trying to accomplish with our people? What's the actual goal, aim, whatever we're trying to do? And then what's the minimum amount of technology? And as you alluded, I'm a nerd, and I like tech, and I have way too many toys, and I spend a lot of money on that nonsense. You need to actually look at what's the minimum amount of technology that you need to get what you need done. So that's a very important part of that. Looking in the ecosystem of technology for all mHealth, all healthcare systems, not just Parkinson's, I think it's very often based on competitive and individual initiatives, which allows for a lot of duplication and efforts. And the collaborative work doesn't always happen. And I think the more we can encourage cooperation between development teams and then the different professionals and the different organizations. And that part of that is sharing some of the barriers and some of the strategies among ourselves so that we can hopefully cut through the noise quickly and get to something that's viable and helpful. So our next steps are to be applying this to specific future projects, and I mentioned the wearables, but we'd also like to support other projects, other interests for people with Parkinson's, and we're looking for anybody that has any interest. We can certainly give your project a run through with one of our cohorts if it helps you. That's it. I'm quick.
Well, we do have time for some questions. Yes. Anyone?
I can definitely talk.
This is your opportunity to, well,
Yes, Linda.
go ahead. And take a microphone.
All right.
Or stand. Yes, if you can stand. Yes.
I'm really interested in the personas that
Yes.
you developed to help guide your development. How did you come up with the persona? Because we're all interested in these phenotypes
Yeah.
of individuals who have different needs and different aspirations. So I'd be interested in knowing how you did that.
Well, and we worked with a group out of California, and it happened to be someone I encountered during, so I do some work with Stanford Medicine X. I'm on a little interprofessional advisory panel, and we took some of those concepts and said, we're going to make this little advisory group, and one of those people ended up having experience here, and so the first thing, when we had our first meeting, she says, you ought to consider looking at this. So I got lucky, no two ways about it. But then I used her guidance to talk about the process of doing it, because as a speech therapist, maybe as an American, I don't know how to say that, I like to talk a little bit, and so we had to learn how to kind of cut down the crosstalk and just listen, and she was very good at that. And then volume, we did a lot of interviews, and not all the interviews were helpful, so you might burn a half hour with something that doesn't actually be productive. You just got to yank it and be willing to burn that time and not worry about it. And then eventually they put the final pieces together, and it was like, again, I live in Colorado. I'm from Ohio. Colorado's a lot more active than Ohio, right? So I have a very skewed sense. I rode a race a couple weeks ago with a guy that had Parkinson's for 7 years, and he beat me up the side of a mountain. But what we found with that particular wearables is that a much larger group in our population, in our community of 30,000 people that we interact with, are more like the low effort guy, and that means that we're going to have to design something that is much more motivational. So it became very valuable information and allowed us to cut through some noise very quickly. So you can hire someone for that, or you can maybe get some advice about how to do it. There's a lot of user-centered design projects out there that you can look at. But if I could say one thing, and I don't always follow this advice, keep the extra talking to a minimum, right? Keep it short so you can listen. Anything else? All right, well, thank you for the opportunity, and thank you for inviting me. I really appreciate it.
No problems. Thanks, John. And now I'd actually like to invite Dr. Jenny McGinley, who's a colleague of mine from Melbourne. Jenny's a doctor she's got a PhD in physiotherapy, and she's actually, her title of her talk is Who and What Needs to Change? Current Challenges in Behaviour Change Interventions to Enhance Lifelong Exercise Habits in People with Parkinson's. So probably bookends quite nicely with John's talk.
Thank you. Let me just start. Okay. Thank you very much for the opportunity to be here. I'm not quite sure where I am or what time it is, quite a lot of the time at the moment. But this is a terrific opportunity, and it's particularly nice, I think, to present in a session like this. I'm a physiotherapist by training. I have a few hats that I alternate, but I guess the hats that I'm speaking to you with today are the hats of a researcher who's been engaged looking at exercise in people with Parkinson's for some time. But also as an educator, I lead education of entry to practice and graduate physiotherapists. And from both of those perspectives, I've, I guess, been thinking a little about some of the behaviour change interventions. From coming from a background of looking at relatively short exercise interventions, I've become quite interested in thinking about how, with many people here, how we help people to maintain activity across the lifespan. I love putting in this quote from Plato that reminds us that we've known for just so long the positive benefits of movement and physical exercise and the harm of inactivity. And that ethos is still captured within our clinical guidelines internationally and nationally. These are our Australian guidelines. They articulate with incredible precision why we should be exercising and the benefits. And a colleague of mine often paraphrases this, I think, quite nicely as exercise keeps us healthy, happy and smart. Despite that, we have a global pandemic of physical inactivity. We recognise the benefits, and we know particularly for people with Parkinson's, we're clear on what the benefits are. Again, there's recognition. There's been a great deal of interest of late. We know that exercise and sustained physical activity can improve movement, can prevent or minimise health risks, help with cognitive, mood, sleep, quality of life, and some of the troubling non-motor symptoms. We know also that there's debate and a great deal of interest in particular modalities of exercise that might be neuroprotective or disease modifying, but we're absolutely sure that it will delay disability progression. Despite that, in common with most of us, people with Parkinson's aren't active enough. As you've heard earlier in this conference, we know that people with Parkinson's have lower levels of activities than their peers. Some very nice work from Newcastle has shown us that people are less active even at the time of diagnosis, with less total activity and shorter bouts. We know that without regular exercise or activity, step count reduces significantly over time. So it's clear to us that long-term exercise adherence is a problem. We're clear that it's key in clinical management and it's recognised in all of the clinical guidelines. So it's equally clear that we need to turn attention to how we would sustain long-term behavioural change. We've seen some really nice work emerge that's given us great insights into what might drive behaviour. We know from Terry's work that she presented earlier that self-efficacy rather than disability seems to be a key factor associated with whether people continue to be active. And that's drawn our attention away from our traditional focus on physical ability. And we also know that low outcome expectation, our understanding of how exercise might benefit, is also a key barrier in why people with Parkinson's don't exercise. We've been doing some work in Australia replicating some aspects to try and understand our community better, to look at what will help people stay active and what makes it more difficult. Along with quant data, we've got some rich qualitative research that again is picking out themes that I think are recognised from prior work. Barriers of time, cost, access to exercise options, and information about exactly what to do. The enablers are clear. Access to expert health professional advice who understands me and my Parkinson's, that gives me very specific and personalised advice that is right for me, that I have access to flexible choices to exercise. And interestingly, the environment became a highlight in some of our focus groups, looking at opportunities for active transport as part of integrated physically active lifestyle. Social support and peer mentors were also identified as key enablers. We've seen over the last decade or so a dramatic increase in studies reporting behavioural interventions as an adjunct to traditional exercise to increase physical activity. We have compelling, positive, level 1 evidence from older adults that may perhaps be generalisable to people with Parkinson's who are also older, about behaviour change techniques that are thought to be effective. And in Parkinson's, we're seeing some emerging and growing evidence suggesting also that integrating behaviour change techniques or management approaches can increase physical activity, with the best recognised trial, the ParkFit trial, that showed that a multimodal approach increased the secondary outcome of increasing physical activity, objectively measured. So if we look to think about how we might work with what we've got right now and the knowledge that exists, we can look very much at the individual and how we help them change behaviour. But I've chosen to take the view of looking perhaps more broadly. So this is local to me. This is me looking as a physiotherapist in my context of Australia. So it may or may not be reflective of your situations. So if we think about the person at the centre of a multidisciplinary team that is embedded with frameworks of service delivery within a wider health system, it's a very, very basic model as I've described it. And think about what the challenges might be to implementing some of the interventions that we know may work. If we look at the multidisciplinary team, perhaps, and the way that we might change our behaviour, we know that low outcome expectations will influence exercise behaviour. We know that provision of information and exercise counselling can improve self-efficacy and influence behaviour in older adults. In a survey of 350-odd Australian adults with Parkinson's, we asked them, have you received any advice or information about physical activity or exercise? A very simple question, and we followed it to try and find out what they knew, where they got it. Of the 357 people, just over half lived in cities, the rest were rural or regional, with a mean duration of around 7 years, so not many newly diagnosed. We found that just over half had received exercise advice from a physiotherapist, but perhaps that just reflects access to service. But in terms of a GP or neurologist, who the majority of these patients would be seeing for medication at regular intervals, certainly only around a third had received advice from their neurologist. When asked, who would you like to get information from? Who do you want to talk to exercise about? There was a clear preference for it to be their physiotherapist and their neurologist, particularly in the focus groups, somebody who knows me well. So what do? We need to work with our colleagues in the medical fraternity, the general practitioners and neurologists within our Australian system. We need them to start a conversation. We need them to provide information about the benefits of exercise. And we need to consider how medical practitioners might routinely screen for physical activity and exercise levels. And again, as Terry highlighted, consider a prescription for medication and a prescription for exercise and an early referral to physiotherapy and a multidisciplinary team. So we have work to do to understand, working with our colleagues, to explore the barriers and enablers to this behaviour of providing exercise advice and referral onwards. If we look to other members of the team, my own category of physiotherapists and exercise physiologists, we know that behaviour change is a specific skill and technique. When we look to trials that successfully implement behaviour health change strategies, we see that there is training of health professionals. You need high-level skills in health behaviour coaching and health behaviour support for the long term. Our entry to practice physiotherapists don't currently come to us with those requisite skills. We certainly have seen some changes in how we are training, but it is a specific skill and we're more comfortable with exercise prescription than perhaps having refined skills at developing action plans, barrier identification, coping plans, and all of the techniques that might go in. So we need to talk to academic colleagues like myself about how we might integrate this information and this training into entry to practice training for future physiotherapists. We also need to consider how we will provide postgraduate training and upskilling of our workforce in these particular skills. In the clinical interface, we also need to consider how we might assess what someone's doing. All clinicians will generally have a conversation about someone's physical activity, exercise and levels. But in talking with colleagues, our tendency is to be perhaps less precise than we need to be. We know that specific behaviours require goals. You need to have defined targets that you're working towards. So we need to have objective and sensitive ways of knowing what someone is doing other than going to an exercise class. We've seen consumer uptake of wearable sensors such as Fitbits. We've seen patients who are coming in with them, but as yet we've not developed systems in place for us to perhaps systematically consider how we might be recording what someone is doing. We also need to consider whether measures of exercise self-efficacy should be part of our standard clinical frameworks. In terms of how we frame our teams, we've come very much from rehabilitation clusters of discipline rather than chronic disease self-management compositions. Within our Australian context, within a Parkinson's community, we're not seeing a great proliferation of the role of the health coach or the personal activity coach role. We are still tending to live within our boundaries, and we don't yet have a defined professional who might have additional training to take that role, as perhaps our colleagues who work in diabetes or heart failure might have. We also don't routinely have health psychologists working within our teams, and we have rich opportunities to engage peer coaches and community mentors to be part of our team working with people. We have strong signals from people with Parkinson's that peer mentors are important, and so we need to consider how might we engage them in a formal sense within our team. In terms of how we deliver care, if you look over on the right, that's Australia with Europe just popped into the middle of it. We're a huge country. We have only 21 million people and we're really spread out. We cluster in little pockets, but we have a massive number of people living there. In terms of access to physiotherapy, let alone physiotherapists with expertise in Parkinson's, it's extremely limited, even in metropolitan areas. And in regional, rural and remote, it might be limited or non-existent. Our practitioners practice less in the public sector, where people with Parkinson's traditionally have healthcare services than private. So we must explore new models of service delivery if we want to enhance behaviour change and physical activity. We need to consider how we might reach. We need to explore telehealth and mobile health, so that we might be able to offer specialised services to support exercise and activity behaviour change in ways we're not used to doing. We know that training in home might give us particular advantage because of the greater relevance and contextual image. In studies of older people, it appears that the mode of delivery of the behavioural intervention is not particularly important, but I'm not sure that we know that in terms of Parkinson's. What we do know from some of our mixed methods and some of our qualitative data is that people would like to have access, the right time, the right support, flexible, timely and responsive access to somebody with training to help them when their exercise plan falls off the rails. And we see that people will go on track, something will happen, it might be associated with a comorbidity, an arthritis, they fall off the wagon, they may have a coping plan, they may not, but they're not able to access what we need. So we need some changes in our service delivery. We need to explore the potential of remote monitoring of physical activity. Wearables are exploding and we need to kind of make sense of what's going on. We need to think about how we might use wearable sensors as part of our routine clinical assessment and integrate it with our performance-based measures. We know that if people are using the conventional and commercially available simple step counters, there is some evidence that tailoring individually tailored walking or step goals might be some efficient. That's in older adults. But we need to figure how do we manage this data that might be useful to us from wearables in relation to our typical clinical data in terms of privacy, storage, and really importantly, the technical skills of our workforce who aren't necessarily adopting the wearables themselves. We have an ageing workforce who may not be using these things, so we need to look at that skill development. We also can explore the potential for monitoring remotely tailoring of community walking behaviour. From older adults not with Parkinson's, there's some evidence that tailored personal goals and information about opportunities in their local environment enhances physical activity and walking behaviour. So whether you're using tracking apps on people's phones, whether we're using Google Earth, those things can perhaps allow us to personalise or to gain insight into somebody's walking behaviour in their community. This is an image from a platform, a digital platform a colleague in Melbourne is working on that essentially will give you a location, you put in where somebody lives and it maps terrain data. So we can estimate how long someone might walk for, what their walking speed is, how to avoid any slopes, and perhaps look at targeted walking routes around the local environment. So lastly, the health system, and I've only popped one slide here because I could go for a very long time. There are many things that might change about the health system we have in place, and we have a change of government, well, not a change of government, an election coming up soon. The priorities for us are equitable access to therapy. Within our Medicare funding scheme that provides funding for medical conditions, if you have a chronic health condition, you can access only 5 sessions of allied health consultations per year. We need infrastructure support for e-health, and we have some steps toward that with the national broadband system so that we're connected to people in their homes. We need support for digital technology as a platform for healthcare to explore telehealth services, which are currently not funded within that scheme. We will not be able to guarantee that each person with Parkinson's can travel to a physiotherapist, and so we have no choice other than to explore these options. We also need to consider how we will train our workforce towards chronic disease self-management skills. So as we go back to consider the challenge of health behaviour change, where traditionally our focus is on the patient, How do we change this person and what they're doing in everyday life? How do we get them off the chair and out and about? I think it's important that we look broadly in both directions. We need more evidence. Evidence is just emerging in Parkinson's. We need to know a lot more about which techniques, how should they be delivered, what's most effective, what is the dosage. There are many questions that we don't know. But at the same time, we need to look towards implementation in a sustainable way within the different healthcare settings that we have, and to be reflective of small gains that might change and knowledge that can be translated now. Thank you. I'd like to finish there and acknowledge my co-authors.
Thanks very much. Are there any questions for Dr. McGinley? Thank you, Mariella.
Hello, this was a very inspiring and necessary talk.
Thank you.
You mentioned it, but I would like, one of the reasons clinical practice and experience shows that people may get out of their programs is injury. Back injury, knee injury, anything that is shoulder injury, and I believe the impact of injury in Parkinson's disease is different. Sometimes, maybe because of rigidity, maybe because of the medication and the muscle tone goes up and down in different ways. But I think we need to raise a bit more of awareness on that, or perhaps you have more data to share with us on that topic.
I think that's a really interesting insight. We know that most people with Parkinson's have multiple comorbidities that need to be factored in. Injury, within our focus groups, when we explored barriers to exercise, injury and fear of injury certainly were conceived as significant barriers. My reflection is also that injury, or perhaps a flare-up of a concurrent comorbid condition, is often something that takes someone off an exercise and physical activity track. It's predictable. So we can talk with people about having action plans, but I also think that's why we need the timeliness of advice. And I'm thinking clearly of someone I know who was struggling to work out what to do with foot arthritis hindering her daily walking program.
And if I may say something, it's great that the world is going dancing and moving. Is marvelous. I couldn't ask for more. But the danger, we are losing a specificity. People are not being followed by therapists who are specifically knowledgeable in Parkinson's disease. And that is one of the, I'm not saying they have to be all the time there, but the coming back and the reassessment and the reinforcement of that is very necessary.
I think it's important that we explore all sorts of options. I agree that dancing is wonderful, and certainly we've done some trials with that. I think it's important that we try and consider what are the most, how we build models so that we're seeing people with Parkinson's regularly to reassess them, to make sure that they're doing the right targeted and individualised practice. The other reflection I have is that a clear signal to us is that people want choices. They might want to go walking some of the time, they might want to go walking and do dancing, or do this, or do that, or change. And we need to be able to give them clear information about what we see as the evidence, the benefits, the risks, the harms of a diverse forms of physical activity.
Thank you.
Are there any additional questions for Dr. McGinley?
I have one.
Hanneke.
I'd like to ask, you said in one of the slides about 5 allied health sessions per year. Does that mean all sessions, or?
Yes. Yes, it does. Within Australia, services are provided in a multi-dimensional way. We have private health systems, we have public health systems. Some people with Parkinson's can access community health care, movement disorders clinics, but they tend not to be ongoing. They tend to be episodic care or regular reviews. We have a chronic disease scheme within Australia that funds medical services, and allied health has only been relatively recently included, and that is 5 sessions per year for all allied health in total. So if you want to see a podiatrist 3 times, which many people do, you might see a physio twice. So we do not have currently, we have very inequitable access relative to the person's circumstance and relative to where they live.
So if patients need a short period of intensive treatment, for example, they pay themselves?
Some do, yes, some do. With people who pay privately do, and some don't have access to that depending on where they live in regional centres.
Thank you, I wasn't aware of that, yeah. Any other?
Thank you so much, Jenny.
Thanks, Jennifer. Then we put in another profession. Our last speaker is Ingrid Sturkenboom. She's an occupational therapist at the Radboud University Medical Center in Nijmegen, and she got a PhD degree this year, cum laude, about her and we're very proud of that because of her excellent work on the effectiveness and the cost effectiveness of occupational therapy in Parkinson's disease. And we're happy that she will share with us her lessons learned from this treatment.
Thank you, Hanneke.
The floor is yours.
Thank you. Well, it's very nice to speak here, and I think it's lovely to have a session like this in the Congress. What I would like to share with you is, we've heard already in some of the presentations the importance of tailoring the interventions, and I think occupational therapy is very much an individualized intervention. And so that the challenges and issues that arise with that when you want to evaluate that in a trial is what I want to discuss with you now. We're all here, all the disciplines aim actually to improve the quality of life of people living with Parkinson's. And well, we know that in the area of physical therapy there is already quite a bit of evidence arising, and we try to use the best evidence all in our clinical practice. But for many of the other nursing and allied health disciplines, the number of intervention trials are still very limited. And I believe that because of the complexity of our interventions, that is part of the reason why we have so limited intervention trials. Now, the complexity of our interventions also already addressed just now was that with behavioral interventions, there are many factors that can impact on the content or the process of our interventions. Now, this is just an impression of some of the factors that influence the content of an occupational therapy intervention, and I think you will recognize a lot of the multitude of factors. And then it can be related to the person, to disease characteristics, comorbidity, contextual factors, but also the expertise of the therapist and what are the different intervention options available. And specific for occupational therapy, I think our domain is on meaningful activities and participation. It's quite a broad domain where what can be very varied for different individuals. Goals can vary from doing up your buttons to painting, gardening, going to the shops, administrative tasks. So it's quite broad. This where we see that in randomized controlled trials, of course, there are very strict rules about how to conduct those, and these are still considered the best, the gold standard for high quality evidence. But then you have to ask when you're looking at an individualized intervention, how can you then standardize the intervention? Is that not a contradiction? And what is a good control intervention that is contrasting and valid? And when you're looking at the outcome measure, how can you make sure that the individualized nature of your intervention is considered in that? So it seems like evaluating an intervention like occupational therapy in this sense is a mission impossible. Still, we took up the challenge with the team and tried to find ways to do this research. And we set up a research project to evaluate an individualized occupational therapy intervention in the context of the multidisciplinary care, because that is also a reality in Parkinson's disease and important. And we succeeded, because in the intervention, in the trial, finally we found that and we had positive outcomes as well, which was of course nice, that people had better self-perceived performance in their prioritized meaningful activities. Both the performance and their satisfaction was significantly higher in the intervention group than in the control group. That was after 3 months, that was immediately after the intervention. And although the effects became smaller after the follow-up time at 6 months, it was still significantly different. And from a cost effectiveness point of view, we saw that when we're just looking at cost, there was no difference between the intervention and the control group in the total healthcare-related societal costs. And when we looked at separate costings, then the institutional costs for admissions to institutions was significantly reduced. So that was nice. And I'd like to share with you the way that we did our methodology and some of the choices we made in order to manage this. So we used, you're probably familiar with this model for evaluating complex interventions from the Medical Research Council. And this is what we definitely adopted as our approach in the whole research project. So what it meant, what is important in this model is that you use a cyclical iterative model as well, that with stepwise looking at developing and evaluating the intervention and then implementing it, but also that you use in your evaluation approach, you use both quantitative and qualitative research methods. So what it meant in our research is that we first had developed the guideline for occupational therapy in Parkinson's disease. Because of the lack of evidence, we, specifically in the field of OT in Parkinson's disease, we used evidence from related fields and combined with expert opinion, but at least we had recommendations for practice. And so that was sort of the development phase. And that we used as our protocol for the intervention for the trial. So then we first conducted a pilot study with mixed methods. And so we looked at the feasibility of doing a large-scale trial and looked at the assessment procedures, the recruitment, but also the experiences with the intervention and the potential impact of the occupational therapy, both from the perspectives of from all participants, so from the perspective of the therapists and the patients and the caregivers. So from this pilot trial, we learned that it was warranted to have a large-scale trial, but we needed some refining of the outcome measures and of the training procedures of the therapist and also the assessment procedures for the research. We set up the large-scale trial. So that was the final evaluation phase, if you think of the MRC model. So we used that phased model. That I think was very important. I think that's very important in doing research like we do in allied health. And we like to stay as close as possible to clinical practice, and so we conducted a pragmatic trial. And we compared occupational therapy of usual care with occupational therapy versus usual care without occupational therapy. And we allowed all Parkinson patients to enter the study if they perceived they had problems in daily activities. And so age or stage of disease was not a restriction, but people needed to be cognitively able enough to be able to fill in patient-reported outcome measures. And because we know the training is, task-related training is context-specific, we conducted a home-based occupational therapy intervention because it's important to do that in the context. And fortunately, I mean, if I hear about context in Australia, the context in the Netherlands is that we are able to provide our therapy in the home or for occupational therapists. So we were able to do that. And although we still kept the intervention individualized, we standardized the process. So the therapist had to follow certain steps in the diagnostic phase and do a collaborative goal setting to decide on the action or the intervention plan together with the patient and caregiver. But the actual content of the intervention was guided by the guideline, but not in a set way. We also used ParkinsonNet-trained occupational therapists. We could use the infrastructure of ParkinsonNet. And this meant that we knew that at least they had training in Parkinson's disease and affinity with Parkinson's disease, and we provided some additional training. But then the choice of the outcome measure was the most crucial part of designing the trial. And because it had to be a measure that was individualized, that had to respect the differences in what is meaningful for people and what would be their goals, and it had to address the domains of participation and meaningful activities. Now, from we really thought the ADL questionnaires that are available are probably not comprehensive enough or relevant for the problems that people perceive. So from the standardized outcome measures that we know from the occupational therapists, we selected the Canadian Occupational Performance Measure. This is a measure that is really able to get individualized priorities for people. People select their own priorities after a semi-structured interview, identify 3 to 5 priorities, and then score these. And what was another important aspect is that we did not only look at efficacy and the economic evaluation, but also looked quite closely into the content of the process evaluation to look at the content of the intervention, the experiences of the intervention. So from that we learned a lot about the black box of the intervention, of the individualized intervention, what was happening, what strategies were used, what was the quality. And then some main lessons that we learned, that although we used the individualized outcome measures like the COPM, and I'm still very much believe that was a good choice, we noticed that even in that measure, the priorities of patients evolve over time. Even between the baseline assessment by the assessor and then the time that they were with the therapist setting their goals. And I think that is what you probably recognize also from clinical practice, that Parkinson patients need some time to reflect and consider their priorities. And in a trial setting, you often want to have, you do a baseline assessment in one session, And that is, I think, something that we need to consider in future trials, whether that is the best approach if you're going for individualized priorities. Another issue that we learned is that and I think that was also addressed now, the importance of the expertise and the clinical reasoning of the therapists. That came out as a very important factor, and it is also something that is really difficult to monitor. And if you want to monitor the content and the quality of the intervention in an individualized intervention, you need to be able to get to grips to this clinical reasoning process. And I think that is an area that is that needs a lot of further research, to look at ways and tools to guide the clinical reasoning and to be able to monitor it, because a lot of the clinical reasoning happens implicitly. And we have the guidelines, but the guidelines only guide clinical reasoning, but it's not a recipe book. So people still consider a lot of the factors that we noted before. They consider that in their choices. And another thing is in the guidelines, the occupational therapy guidelines, and that is due to the limited availability of evidence for more the very early or the advanced phases of Parkinson's disease, is that the therapists actually found those groups the most difficult to think of the interventions. So that is another area that I think is in great need, and I think that was recognized in other sessions as well, that we need to know more about what are good interventions and approaches in the advanced stages of Parkinson's disease and when people have more cognitive problems. Now, there are more lessons that can be learned from doing a trial like this, and I have here some links to my thesis, my dissertation, if you're interested to find out more. And these are PDF, you can access the PDFs. I also have some actual hard copies for people who are really interested. I'm not intending to take them back, so please, if you like to have them, come over and grab one. And I think the main message I wanted to bring across from my study was that, yes, evaluating individualized intervention, it is challenging, but it is possible if you take it step by step. And yeah, with any research, it often poses more questions than answers, but it's a start, and I think it's something we need to build our evidence base for allied health interventions. Thank you.
Thanks, Ingrid, for this very inspiring talk. Any questions? Any other ideas? Who was thinking about starting an RCT about a complex intervention? Go ahead.
I tend to know your work, but so what were the types of activities that were approached in your intervention? Were there any common patterns of what people selected? How did you get, I think a real challenge to us is getting activities into the routines of individuals. So can you talk a little bit about that, the content of the intervention?
Yeah, the content could be very varied. What we noted is, I looked at the type of priorities that people had, and a lot of the priorities, a lot of the priorities involved still mobility-related activities, and that could be like mobility-related in going to the shops, or doing more the transfers in the house. But it was very varied, and it could be related to looking at more efficiency so that it would take less time and effort to conduct the activities. But it could also be, like you said, like be looking at expanding their activity pattern or looking at the right balance in their pattern. So it could actually be anything. It was very varied, and I think that was, we also looked at the type of strategies that were selected most by the therapists, and the strategies that were used by the clients at the end of the intervention. And there you also see many different strategies that could be used. And different strategies, like more strategies than one for one activity. So it was quite complex, but in the article on the process evaluation there is some more information, detailed information on that.
Other questions? Well, I might have one myself, thinking back about what we just learned. Oh, Marielle?
What about queuing? Were they talking about queuing? Were they aware of the specificity? Because you're relating to mobility. Mobility in Parkinson's doesn't belong to anybody, just only to people who try to move. And then we will be using the strategies for that. Were they talking about that?
Yeah, queuing was one of the strategies that was used. It was actually quite surprising that the use of queuing strategies was lower than I would have expected from the number of mobility-related problems that people had expressed. And the reason for that, I can't really get out of the case records, because I looked at the case records. Sometimes it was tried, and then people did not like to use it, and sometimes it was not really even tried, but mostly, So it was less than I had expected, but it was part of the strategy that could have been offered by the occupational therapist.
Maybe the therapists need to learn more how to offer it.
Yeah, well, we spent quite a bit of time in our training of the occupational therapists to use queuing in various activities, also in more upper limb movement related activities. And we also really stress the importance of the collaboration with the physical therapist on that. So, and I mean, in my study, people could collaborate with the physical therapist if need be. So,
okay, thank you.
Yeah.
Anyone else? Well, to raise further discussion, we just learned that in Australia, the maximum of treatment sessions is 5. In the Netherlands, for occupational therapy, it's 10.
10 hours per year.
Was 10 hours enough in this trial to set the goals and to achieve the treatment goals with patients?
Yeah, that is often the occupational therapists in the Netherlands are complaining that they don't have enough time. But what we actually notice is that not all the 10 hours were used. If you looked at the mean hours that were used, people spent quite a bit of time on the diagnostic phase to really get to the most important issues for the person, and then they see that the other, you can be quite efficient then in your therapy. But I mean, what we noted is that the effect became smaller over time. So it does suggest that people, and that was over a 6-month period, that a follow-up after some time, I mean, that is what we really like, is that we're still able to follow it up and maybe look at some new issues that come up, some new problems. Yeah.
I saw someone waving in the back. Yes, go ahead.
I have a terrible English, but how to interplay with physical therapist, psychological or a speech therapist, that personal goals from the patient, because we work to walk, but to walk for what? To cross the street, to be to be well, but how to interplay with the team, which are the personal goals and what the patient expects. Because if not, we are all asking the same thing, but you have a way to assess a lot more accurate for that.
Yeah, well, I hope I interpret your comment or question right. The occupational therapist would actually spend quite a bit of time to get to the goal setting, priority setting, and that is really related, or that's really at a level of activities and meaningful activities in the sense, for example, going shopping. Then if one of the underlying reasons for the difficulty is because of the mobility, then the OT would collaborate with would ask, well, is there a physical therapist involved? Can I contact them? Because this intervention was home-based, so it's not from a center, and your colleague physical therapist is someone out in the community, that it's not necessarily a set team. Like every time you have to collaborate with someone else, but you would find out and you would go to the physical therapist and discuss, okay, what will I do, what will you do, and then work together like that.
Is that an answer for what you were thinking of? Mm-hmm. Yes, because patients have several goals and so many things they want to preserve or want to achieve. Yes, that's absolutely true.
Yeah, no, that's true. And I mean, I really noticed in my research as well that the collaboration is not always, like the quality of the collaboration is really important. And it seemed to depend still too much on personal issues, like how the professional's attitude is towards collaboration from both sides. And because the study had to be conducted in a certain time frame, what you also notice is that, like, to have access to the other discipline in a timely manner is also still an issue. So I think in the area of the multidisciplinary collaboration or interprofessional collaboration, or whatever how you call it, is that there needs to still be a lot of work that needs to be done. Definitely.
Great, thank you so much. I'd like to thank all of our speakers who've freely given their time and put some considered effort into some amazing presentations today. So I'd like to thank our speakers. But most of all, I'd like to thank you for attending and to actually making the long walk down to the far end of the building to actually attend the session. And I really hope that you found it beneficial.
See you next year. Mariella.
Asked me to give you the very good news that we have the third Movement Disorder Society Physiotherapy Summer School that will take place in Leuven. The second weekend of September. I think it is the 7th, the 8th, and the 10th, more or less. Look at the website. Don't miss it. Some of the speakers are here. Please raise your hands. It will be fun, and we will love to have you there, so we can all keep on learning together. Thank you.
Thank you. Well done.